there has been a significant improvement in our ability to manage primary bladder neck obstruction. And I would attribute this to two important advancements. One, an advancement in technology, and the other, an advancement in our understanding of biological processes. Our technological improvement has been the precise diagnosis that we get with video-urodynamics. Now, urodynamics is a test where we measure bladder pressures. So in a sense, when we are trying to prove obstruction, it's like you're sitting in a room and you're trying to open the door. If you can show that the bladder is pushed very hard and yet the door has opened very slowly, that would be characteristic of an obstruction. But a video study enables us to locate or identify the obstruction with much greater precision. So you can see the location at which the obstruction happens. Some young men can have obstruction at different locations, like at the striated sphincter, or there may be a passable stricture. All those things can be ruled out confidently when we do a video study. So video-urodynamics is a technological advancement which has made it possible for us to make a precise diagnosis. Now you can see this video-urodynamics study, and what is apparent here is that when the patient tries to pass urine, you can see there's a very high pressure generated, and yet the flow of urine is very slow. It's as if you're sitting in the room, you're pushing at the door very hard, but the door is opening very slowly, and that tells you that there's an obstruction. But what the video part of the study does is, it tells precisely where the location of the obstruction is. And that can really help us clinch the diagnosis of a primary bladder neck incision. Because the last thing you want to do is to give a bladder neck incision or do a surgery in a patient whose location of obstruction is at the sphincter level, for instance, in which case the surgery wouldn't help at all. So doing a video-urodynamics is a precise method of getting a diagnosis. We also have some data now, and this is a study that was published by us along with our colleagues from All India Institute of Medical Sciences in Rishikesh, which showed that if you do a video-urodynamics, you can make a more confident diagnosis of primary bladder neck obstruction. So without resorting to a video, the diagnosis of primary bladder neck obstruction was made less often, thus denying some patients, presumably, of treatment that would have otherwise been effective. We also have more recent data now in terms of how to make a diagnosis of obstruction. How much should be the pressure that the bladder generates? How slow should the door be opening before we make a diagnosis? And this is the ICS SUFU standard that we published recently along with our international colleagues, in which very clear definitions have now been provided. This was published last year, and there are several new changes to our the diagnostic criteria, especially in terms of making a diagnosis of intermediate obstruction, or in terms of making a diagnosis of bladder weakness. So I would recommend all urologists who are interested in the field to read these new documents, because they have a wealth of information in making a diagnosis. The other important advancement that has happened to enable management is an improvement in our understanding. The conventional surgery that was done for primary bladder neck obstruction entailed making an incision all across the bladder neck, going up to a small structure in the urinary passage, which is at the 6 o'clock location on an endoscopy called the verumontanum. Now, making that incision was a reliable method of relieving obstruction, but unfortunately also caused problems with ejaculation in up to 30 to 50% of patients, and that was clearly not acceptable for patients who are unmarried or who have not completed their family. Recent understanding of the biological process of the ejaculation function now enables us to do a more limited incision called an ejaculation sparing bladder neck incision that can improve symptoms or relieve obstruction while preserving the ejaculation function. Now you can see here, this is an endoscopic view of the prostatic urethra in the bladder neck region. At the 6 o'clock position on this endoscopic view, you can see a small nubbin of a tissue, and that is the verumontanum. That's a normal landmark that we have inside. And above you can see that from our endoscope at the level of the verumontanum, you can't really see the bladder. So this, we are at the bladder neck. Ordinarily, it should have been possible to see a wide open bladder neck. We don't see it here because there is an obstruction at the bladder neck. This kind of an appearance of an elevated bladder neck with an obstruction is suggestive but not entirely conclusive in making a diagnosis, which is why you need help from the video-urodynamics to make this diagnosis. Now you can see in the original operation, we would have made a cut endoscopically, which went right up to the verumontanum. But in an ejaculation sparing incision, we make the incision up to a point around a centimeter, roughly 10 millimeters short of the verumontanum. And in making this kind of an incision, we are able to preserve ejaculation while relieving obstruction. And you can see this is the uroflow or the non-invasive flow rate of a patient before and after surgery, showing how obstruction can be relieved with an ejaculation sparing bladder neck incision. The data with regard to ejaculation sparing bladder neck incision is more recent, it's more limited. Hence, it is always wise to advise patients to preserve their semen by semen banking, just as a sort of an insurance, just in case they have trouble with their ejaculation. And it's possible that in some men, we might need to make extensions of the initial incision to relieve obstruction completely, but it's uncommon to require that. So at this point, for men with primary bladder neck obstruction who have not completed their family, an ejaculation sparing bladder neck incision seems to be an effective method to relieve their problem without the concomitant problems with ejaculation that used to occur with the original operation.